interstitial fibrosis, bronchiectasis, pleural effusions. That's
and in the previous course,
I think it was just general stuff about.
did you study the alveolar syndrome?
Yeah, I believe so.
Okay. Okay, so we're going to start with the pleural syndrome, and I think we should do pleural syndrome, parietal syndrome, and maybe alveolar syndrome, depending on how well it goes. So here it goes. I will start my presentation. Just a moment. Okay, so can you see my slide?
Yes.
Okay. So here are listed some of the main causes and diseases that could lead to pleural disorders. These are effusions, which represent some kind of fluid collection within the pleural space, within the two layers of the pleura, the visceral and the parietal pleura. The accumulation of air in this space, which leads to pneumothorax. And if we have a mixture of air and fluid within the pleural space, then we talk about hydropneumothorax. The solid lesions that we can find in the pleural space are mainly represented by mesothelioma, which is the primary tumor of the pleura, and by pleural metastases. These are the main things that we will talk about. There are some other causes somewhere along the slides. I will list all of them, but these are the main subjects. Starting with which I think is the most simple condition, is the pleural effusion, which its appearance is dependent on the quantity of fluid that we have between the pleural layers. So posterior and anteroposterior films are quite insensitive to small amounts of pleural liquid. It takes about 250 milliliters of fluid so that we can see the pleural effusion on a chest X-ray. First signs will be the blunting of the costodiaphragmatic angles. The first one that will become blunted is the posterior, because it's the deepest of the costodiaphragmatic angles. So small amounts of fluid will be first seen here in the posterior costophrenic angle. So the lateral chest X-ray, the lateral view of the thoracic film, is the best way to try to find these small effusions. Eventually, as the fluid begins to accumulate here, there will be this meniscus with concavity superior, blunting the costodiaphragmatic angles, first laterally, then extending towards the medial part in the cardiophrenic angles. If the fluid keeps accumulating, then we will have this slope, this superior concave slope that ascends onto the lateral thoracic wall with homogeneous opacity, blunting the costodiaphragmatic and cardiophrenic angles. The fluid can also accumulate in the pleural fissures, and when there is a large amount of fluid, merely about 5 liters, there will be a total opacification of the respective hemithorax. So these are the main signs. The main characteristics of the pleural effusions are that these opacities are homogeneous. They have this concave superior border that ascends on the lateral thoracic wall. They blunt the structures that come in contact with the opacity, like the diaphragms, the borders of the heart, and so on. And they are homogeneous, and their intensity is the highest in the most dependent areas. There will be the most fluid in the more declive and dependent areas. So here is an easy example in which you can see the blunting of the both lateral costophrenic angles with this meniscus and ascending line towards the thoracic wall, which suggests a small pleural effusion. The border of the opacity is concave to the superior aspect of the cavity, and its highest peak, it's laterally. That's the way it evolves from the lateral, where is the highest, to the medial. Okay, the same thing on the lateral view. Here you can see that we can easily detect the small amounts of fluid in the posterior costophrenic angles. Also, you can maybe find some causes for this effusion. Can some of you tell me which is the most probably diagnosis for this pleural effusion?
Is it lobar pneumonia?
Why so? Do you see any pneumonic opacities?
Yeah, I think so, at the bottom.
At the bottom, on which side?
Probably right on both sides.
On both sides, so you mean these regions here?
Yeah.
Okay. This is only if you carefully watch these markings. These are normal or a bit increased in size vascular margins. There are some other clues that can point you towards the right diagnosis. Someone
Is
else.
it congestive heart failure?
Okay, most probably. What makes you say that?
The enlarged cardiothoracic index of the heart?
Correct. Something else. Clue.
The cephalization of the veins in the upper lobes?
Correct. There is a cephalization of the veins, so the vascular distribution tends to go also towards the upper parts of the lungs. When we remember from the last workshop that the vascular markings are most proeminent in the lower parts of the lungs and very tiny at the upper part. Here tends to be an equalization between the two. Another thing. There is a procedure that maybe this patient had, and we have the clue for that. Do you know?
The sternum has like stitches.
Okay, the sternum has metallical stitches, which suggests that the patient had a previous heart surgery, maybe for some kind of heart disease. There is also on this frontal chest X-ray a normal anatomical feature that can be seen, a variant of an anatomical structure. Can you identify it? Besides everything else we discussed about. It's a normal anatomical variant.
Something with the arch,
With what arch?
the aortic arch.
No, maybe it is a bit more proeminent. That I think it's also in the context of cardiomegaly and maybe hypertension and maybe some atherosclerotic aortic changes. But it's something else. What do you think is this structure here that is connected to this line here that extends all the way to the upper pleura? Joachim, is it?
Yeah, that's me.
Okay. Do you know what this structure is?
No, I have no idea what that is.
Okay, someone else knows. So nobody. Okay, this is okay. Sorry. Yes, please.
Yeah, is it a stent?
A stent. Where? Put where? Ovidio.
Yeah, I'm not sure.
Okay. Basically, it's projected on the upper part of the lung. Is supplementary fissure is called the azygos fissure and interconnects the opacity of the azygos vein with a fissure that delimitates a supplementary lobe in the right lung, which is called the azygos lobe. So it's an extra fissure. You can see this in many patients, and it's something normal. It's just a normal anatomical variant. Okay, it's not a stent because it should have been along the projection of a vessel, and here is in the lung. So that was that. Okay. Another thing that we have to know about pleural effusion that are free in the chest cavity is that when we lie the patient in a supine position, so lying on his back, the fluid will uniformly diffuse all over the hemithorax. So it will create a diffuse opacity, an increased diffuse opacity of the respective hemithorax compared with the other one. This is a sign that the pleural effusion is free and it is not loculated in the pleural cavity. So we use this sometimes in order to see if the fluid is free or not. Surely, and the most easy thing to do when we are confused and not sure about the opacities is to do chest CT. This will tell us any information that we need to know. We will find maybe additional causes for the etiology of the pleural effusion. What we can do extra from the X-ray is to kind of analyze the content of the fluid, with what kind of structure does it has, what kind of density, which we can measure using the Hounsfield scale. In this case, we see that there is a bilateral pleural effusion because on the CT scan, the patient lies on his back. It will be present in the more posterior parts of the thoracic cavity. And what we see in front of the pleural effusion are some small parts of collapsed lung, because it is compressed by the fluid in the pleura. So much more easy and much more information that we get from the CT. Also, higher dose of radiation. So you have to keep that in mind. In the cases of large pleural effusion, we have to keep in mind that the opacity that we will see will determine a shift in the mediastinum, because the fluid expands the hemithorax. It will push away from the opacity the mediastinum, as you see in this picture. So we have a large pleural effusion, a large pleural opacity, that it is homogeneous with it is quite intense, and it is the most intense in these regions where is the most fluid. It has a concave superior border. It has an ascending line on the lateral chest wall, but supplementary, because it's so large, it determines a shift in the mediastinum, which goes away from the pleural effusion. It is pushed towards the right, and we can see this is the transparency, the lucency of the trachea, which is moved to the right. The same thing happens to the right border of the heart. So the mediastinum is shifted because of a large pleural effusion. Also, what you can see, there is a bit of difference between the spaces, intercostal spaces between the ribs. Here on the left side, where there is a lot of fluid in the pleura, these spaces are a bit larger compared to the ones on the right side. So keep in mind, it's a thing that you have to describe when you see this kind of pleural effusion. You have to describe the basic characteristics of the opacity. That is homogeneous, intense, depending on the amount of fluid, and if there is a large amount of fluid, it will be most intense in the most dependent area. The superior border is ascending on the lateral thoracic wall. The superior border is concave, and also, if is a large pleural effusion, it will determine a shift on the mediastinum, moving it to the contralateral side. What we have to say, and we will discuss further when we will talk about the alveolar syndrome, is this silhouette sign. Basically, this liquid in the pleural cavity it determines the loss of the silhouette between the lung and the heart, and also with the diaphragm. So we have no more borders of the heart and diaphragm, because they are lost in the contact with the pleural fluid. Okay. A special type of pleural effusion are the loculated pleural effusions. Can someone tell me where is this pleural effusion located and loculated? Using these two.
In the middle lobe of the right lung?
Okay, it is basically on the horizontal fissure, because this opacity here that looks like a lentiform shape, and even better seen here on the lateral view of the chest X-ray, it is projecting on the course of the horizontal feature. So these views are very useful and in describing and detecting the loculated pleural effusions, especially when they are located along the fissures of the lung. So in some cases in which we have a pleural effusion associated with some kind of previous diseases of the pleura, this fluid tends to accumulate and to loculate in some places. This can be anywhere on the pleural surface, in the apexes, in the laterothoracic part of the pleura, in the posterior part of the pleura, near the mediastinum, or along the fissures in the between the two pleuras in the fissures. They have this usually this typical lenticular aspect. They are homogeneous. They are with a medium high intensity, and they project on the course of the fissures or on the lateral thoracic wall. And when they do, and when we see them in the lateral projection, then we will see that the angle that the opacity has with the chest wall, it is an obtuse angle. You will see in a minute. So loculated pleural effusion, in this case, along the horizontal feature. So it's not quite in the middle lobe of the right lung. It is along the fissure. It is a pleural opacity, not the parenchymal or intrapulmonary lung opacity. Okay, and also what you can see that these effusions are very well circumscribed, especially and because they are lined with pleural layers. Okay, what can you tell me about this frontal film? I will just name one of you so that I can get answers maybe from all of you. So Aline, I will start with Aline.
Yes, I'm here.
Okay, so just give me a second so that I can make a screenshot with the presence. And in a moment, I will show you again the film. Okay, so this is it. Oh, come on. Okay, Aline, so tell me, what can you say about this film? And let's try something. When we look at the film, we discussed in the previous workshop that we have to first determine if that examination was performed correctly. So start with this. Is this a correct anterior chest X-ray? And if not, why?
Let's see. I don't know. I'm not very good at this. I can't see.
We are not, because it's the second workshop, so we're trying to.
So first of all, I think we should look for foreign bodies which are there. So she had
Okay, let's just for a minute leave aside the diseases of this patient and just tell me if this is the correct performed chest X-ray. What do you have to look for?
If it's centered, so I think.
Okay, is it centered? What do you look for?
We should look for the medial part of the clavicles, and in the middle line
Okay, here are the medial parts of the clavicle, and we have to look for the midline along the spinous processes, which are a bit turned around. I think here you can see them, so it's quite rotated. Okay. Another thing.
If it's I think posterior anterior or the other way around.
Okay, how do you think this was done?
I remember with something the scapula, like if we see it, then
I think it's posterior anterior. The scapula is quite out of the picture. Only here we can see a bit of the medial part of the scapula. And I think it's standing position, not on the side, not on its back, because of the features of some of these opacities. So it's a posterior anterior projection. Another thing, what should we look for?
The inspiration, maybe.
Okay, so we need to know if the patient took a deep breath before the film was made, in order to make sure that there was a correct amount of air filling his lungs, so that we can distend properly the lungs. So we go ahead and measure how many ribs in order to determine that.
For the either 6 anterior, 9 posterior, I think.
Okay, 6 anterior, 9 posterior. I start with the posterior. So here is the first 1, 2, 3, 4, 5, 6, 7, 8, 9. It's at the limit, but it's fine. Okay, Alim, that was very good. Also, what we have to look for is to have in the film, captured in the film, all the anatomic regions of interest. So we don't need to cut the apex of the lungs, we don't need to cut the costodiaphragmatic angles, and we also usually have to see the soft tissue of the thoracic wall. Okay, so moving along to the pathology of this patient. Aline, we will let someone else, for example, David. David, you with us? Okay, so no. Ece?
Can you hear me?
Oh, I can hear you. Okay,
Yes,
David.
I have an extra microphone which doesn't work like really well.
Okay. So what's wrong? What do you see on this chest X-ray?
Hang on. I see the spine is weirdly curved.
Okay, forget the spine. It's a rotated frontal chest X-ray. We barely see the spine. It's not the point of this exam. Something else. And you also have to keep in mind what we discuss, because it's related to the subject, usually.
I'm sorry, I just have to say we have an ortho exam tomorrow morning, so that's probably why he was looking at the spine.
Oh, I see. But you will have to have a different kind of X-ray to analyze the thoracic spine. And hopefully you will learn much more MRI for this kind of pathology than X-rays, but well. So let's focus on the thoracic and pleural and pulmonary pathologies here.
Maybe it's a right side pleural effusion.
Okay, I think most certainly there is a right-sided pleural effusion. Why do you say that? You have to be more convincing. You have to sell your arguments.
Because it's very bright. It looks like it's filled with liquid.
Okay, this here, this opacity looks quite bright, but you have to specify the things that we pointed before. basically you see some kind of an opacity that blurs or blunts the costodiaphragmatic angle on the right side. It is an intense opacity. I agree with you. It is homogeneous. It is concave. So it is most probably a pleural effusion. What else? What is this?
I'm not sure.
You have to think that these problems are most of the time in connection with each other. So if you see this opacity that blunts the costodiaphragmatic angle, that almost continues here on this area, maybe you should think that that effusion fused in this region. And what kind of structure can we have here where the liquid can fuse in the pleural space? It is a
Horizontal fissure.
Okay, it is a fissure. So what do you need to do in order to confirm your suspicion that there is a fused pleural effusion in the fissure? What is the next step?
Paraclinically or like the clinical, the next clinical
Oh,
step?
like radiologically. 'Cause
Take another X-ray from the lateral view, from
Perfect.
that side.
That's the thing to do. Before we do that, do you have something to say about the other costodiaphragmatic angle on the left side?
I don't know. Probably it's the same thing, but I cannot tell for sure.
You can be sure because the normal aspect of a costodiaphragmatic angle is this kind of sharp angle that you have on both sides. Look at here, where is there is no major effusion here, so the angles are sharp. Here it is obviously blunted in this part on the right side, and it is a little bit blunted on the left side, and it continues along the wall, the thoracic wall. So most probably there is a minimum pleural effusion on the left side also. The foreign bodies that someone talked about are the metallic sutures on the sternum, and here is an prothetic valve superimposed on the cardiac opacity. Can you tell me something about the heart, the mediastinum, the shape of the heart and its dimensions? David.
Maybe there's a pericardial effusion.
You
Right.
go too directly into the diagnosis. You have to start with the baby steps, like there is an increased cardiothoracic index, like your colleague said earlier, because we can do, I don't know if I showed you, maybe I didn't show you last time, but we can do measurement between the both edges of the heart, the right and the left. This will be quite nasty, I'm sorry. So we will measure this transverse diameter of the heart, and we will compare it to the widest diameter of the thoracic cavity. And if it's over 50%, that means it is an increased cardiac size. This is called cardiothoracic index. So the heart is enlarged here. We cannot know for sure from this frontal view and this chest x-ray if there is an associated pleural effusion. I think that the heart is enlarged because of the valvular disease of the patient and the long-standing cardiac condition, which also led to the pleural effusion, because you know by now that pleural effusion is associated with heart failure. Okay, so like you asked me, you had to take lateral view in order to confirm the origin and the location of this opacity. So thank you, David. And next will be Ece. Is this how I can call you?
It's Ece.
Ece. Okay, Ece. Tell me, what can you say more on the lateral view?
What more?
So we determined that we have a small medium pleural effusion on the right side with the possible extension into the pulmonary fissures. Can you say on this lateral view what kind of effusion is there in the fissures? Where is it?
It's the major fissure.
Is the major fissure, first of them. Here you have this fusiform opacity, very nicely delimited and perfectly situated along the major fissure's trajectory. And here is in the posterior part of the major fissure is the most important component of this loculated pleural effusion, but it also extends a bit until the anterior part of the major fissure, even though it is a little bit thinner, but you can see it continuously from the posterior aspect to the anterior aspect of the fissure. This is one. And the other one, which we probably see here, is located along the minor fissure, the horizontal fissure, and we have this like the trifurcation aspect, all opacities being situated along the fissures of the right lung. So this is pretty easy diagnosis to make. So you see an enlarged heart with multiple metallic sutures on the sternum. You see prothetic valves over the opacity of the heart, and you have this kind of opacities in the costodiaphragmatic angles, which are highly suggestive of a pleural effusion. You get another opacity that is projected somewhere along the one fissure of the lung that we confirm on the lateral view, that is situated both on the major fissure and also on the minor horizontal fissure. Okay, Ece, I am not done. What can you say about this one? So let's start the same as with your colleagues. So tell me if this is correct performed chest X-ray.
It looks centered.
Okay, it is true. It is quite centered. I will help you by doing some drawing. So here we have the midline between the sorry. I need a pen. So between the spinous processes of the vertebral column, sorry, I'm not quite good at this, and we have a quite equal distance between the medial heads of the clavicle. Okay, is it a good inspiration?
Yes, there is no collapse.
How many posterior ribs can you count?
8. Is it?
8. I count 10. So here is how you count. Again, this is the posterior arch of the ribs, yeah? So this is the first one, the second, the third, the fourth, 5, 6, 7, 8, 9, and 10. So this is a quite good inspiration film. Okay. We have the costodiaphragmatic angles on the film. We have the apexes of the lung. We miss a bit of the soft tissue, but is a good performed film. So what about the disease that you can identify here?
Blunting on the left in the the costodiaphragmatic angle on the left side.
Okay, there is a blunting of the costodiaphragmatic angle. Okay. How would you describe the opacity? You have, when you describe an opacity, it doesn't matter the kind or where it's located or which kind of film are you looking at. You have to describe this particular features. Its location, its approximate dimension. If you can do that, I will show you how in a few minutes. The structure, the intensity of the opacity, the contours, if they are smooth, regular, sharply delimited, and other associated features that you find with the opacity. So how would you describe this one?
It has smooth, clearly demarcated margins.
Okay.
I would say.
Towards the margin or towards the lung? How would you say? So it's sharply delimited towards the lung. Okay, and it is a bit more diffuse and blunting, as you said before, towards the costodiaphragmatic angle. Okay. Another, is the structure homogeneous or inhomogeneous? Heterogeneous.
Homogeneous.
Okay. Is the intensity small, medium, or very intense?
Medium, I would say.
Okay, it is good. It is a medium intensity. When we characterize the intensity of an opacity, we usually compare it with the one of a rib. So this intensity is quite a bit higher than of a rib. Here, where it's not overlapped with other arches. So rib here. Yeah, it is more intense. So it is an intense opacity. Okay. What do you think? Do you think it's a simple pleural effusion, or do you think it's something more? What would be your diagnosis after you described all these features? So what's the diagnosis?
A pleural effusion, but it doesn't seem to fuse.
Okay, it seems a bit stuck, hanging there. Okay. So what can be?
Sure.
It could be a loculated pleural effusion. Okay, that, but this time the loculation occurs on the lateral thoracic wall. And when this happens, and we basically see this effusion from a lateral view, we see this ascending obtuse angle with the thoracic wall, and here also with the diaphragm, but without the whole characteristics of free pleural effusions, because if this pleural effusion would be free, it would extend to the both edges of the thoracic cavity. So another feature to determine whether a pleural effusion it is free or it is loculated, it is to observe if the effusion is extended between the both edges of the thoracic cavity. In the case of this opacity, it stops here somewhere, and this seems a bit suspended or stuck along the lateral thoracic wall. So it is a loculated pleural effusion along the lateral thoracic wall. It is it is possible that here can be a little free fluid component. So in order to be very, very sure that this effusion is loculated, what can we do extra? What would you do next to confirm that this effusion is loculated in the lateral pleura? Ece, do you have any ideas?
I don't think I know this.
Okay, so let me continue with Elias.
Profile
Okay.
X-ray?
Sorry?
A lateral X-ray?
A lateral X-ray. But when you will project this on a lateral X-ray, differently from the fissure loculated effusions, it can give you a weird impression that is projecting somewhere in full parenchyma of the lung. So it can be a bit confusing because it's a bit different from the other effusions that we saw before. These are typically seen on the lateral chest X-ray, but this being more laterally here along the lateral pleural cavity that lies on the lateral thoracic wall, it can be a little bit tricky. Do you have another idea?
Maybe like a CT?
Okay, before the CT, because it's easy with the CT. Everyone knows with the CT. Another thing, I said before, there is a thing that we could do in order to determine if a pleural effusion is free or loculated.
Have the patient change position.
Exactly, have the patient change position. So, Nicholas,
Hi.
what exactly do you expect to find, and how would you change his position?
That's a good question.
I thought you already had the answer if you said.
Yeah.
So,
maybe.
How is this
Have them
done?
have them lie. We'll have them lie on the affected side, and then, well, they're standing in this picture, right?
They're standing. So what is the most obvious thing to do if this is made standing? And
lateral decubitus.
I'm not very sure why you complicate a bit the thing. You just have to lay him on his back.
Oh, okay. So yeah, lay him down on his back.
Lay him down on his back, and if it's a free effusion, it will uniformly spread along the left thoracic cavity, and we will be certain there will be no more loculation on this area. If we lay the patient on his back and we'll still have this image here, we will be certain that there is a loculated pleural effusion. So,
Okay.
okay, but good idea, just it's a bit complicated, and we very rarely do thoracic films with patient lying on their lateral side. It's a bit, I don't find their utility, and I don't see them done. So just, these are the basic things.
Okay, I'm going to trust you on this one.
Sorry?
I'm going to trust you on this one, doctor. Thank you.
Okay. So the basic things that we can do is a posterior anterior film, a lateral film, and a supine film, or film performed with the patient laying on his back, in order to determine most of the informations that we need to know. Okay, so keep in mind that when you see this kind of laterally loculated effusions, they can give you this homogeneous opacities with obtuse angles forming with the thoracic walls, with blunting of the costodiaphragmatic angles, and with no change in position, in form and aspect, with changing the position of the patient. Okay, moving along. It is kind of the same thing, but I don't know why this was larger on my slide. Sorry. It's quite the same thing. It is laterothoracic, left laterothoracic opacity here, which is quite homogeneous. It is well delineated towards the lung, a bit blurred towards the chest wall. Sorry again. It has quite intense structure compared to the ribs adjacent. It is quite big. And if we perform, obviously, a chest CT that most of us would probably do, we will easily depict this loculated pleural effusion that you can see like a lenticular fluid accumulation on the lateral thoracic wall that is basically suspended here. Imagine that this CT is done with the patient lying on his back, and the fluid, if it was free, should have been positioned somewhere here in the posterior region of the cavity. But the fluid, because it's loculated and suspended here, it doesn't change position with the decubitus. Okay, so what about this one? And this will be Elias. Please. We will talk first, sorry, we will talk about this image here. Is Elias with us? Elias, you left your computer running without you. Okay. Halime?
Hello, I'm here.
Hey.
Yes.
How would you describe that?
It's like a high opacity.
Okay, perfect.
Increased opacity. Is there's a deviation of the
What you have to say a bit more is, I agree with you, is a high intense opacity, but you have to say something like it covers the whole left hemithorax. You have to locate it a little bit
Okay.
so that we can be sure what we're talking about. Okay.
High opacity located on the left side, and on the left picture, it looks like it's pushing the mediastinum towards the right.
Correctly. What does this arrow point here to? What is that structure?
It's the throat. We forgot.
Is the, sorry, I didn't understand.
It's the throat, the trachea.
The trachea, yeah, the windpipe. Okay, is the trachea. We can nicely see it here because it's transparent a little bit, similar to the lung because it's filled with air. Okay, and the trachea is moved to the right side. And also, I agree with you, the right side of the heart is also moved towards the left. So away from this huge, massive opacity that we see on the left hemithorax. So what is your diagnosis in this case?
Could it be like blood?
Okay, so when I am asking you about the diagnosis, is not, I don't refer to specifically say what kind of fluid is in there, what structure it has. We have to firstly, and especially on the chest x-rays, to determine whether it is pleural opacity, and if it's pleural opacity, if it's pleural effusion, if it's a tumoral process, or if it's air, for example. So this would have to be your first diagnosis. It is a pleural opacity, it's a massive pleural opacity, most probably given by a very important pleural effusion. Now, in order to determine what kind of content and structure does this effusion has, you have to perform some other kind of investigation. And most probably in this setting here, what would you do to determine what kind of fluid you have in the pleural cavity? What kind of test will be the next step, in your opinion?
You mean like a paraclinical test, or like
anything you think is best? What would you do, like a doctor, if you see this chest X-ray?
Take a sample if I can.
Okay, take a sample. You will do a pleural puncture. You will take some of the liquid out, firstly to alleviate the patient's symptoms, because surely it's not quite asymptomatic in this setting. And by doing that, you relieve the symptoms, and you will also have a sample of what fluid does that pleural cavity contain. So this is how you basically put the diagnosis if you want to determine whether the fluid is exudate or a transudate, whether it's hemorrhagic, whether it's neoplastic, or what kind of cells and other biochemical components does it have. But when you see a chest X-ray, we have to establish the easy parts. What is the diagnosis? Is it pulmonary opacity, is a pleural or parietal, or so on and so forth? So I hope you understand what I asked. So it's not necessary for you to say it is hemothorax or it is chylothorax. You have to say it is a pleural effusion, very large one that has a mass effect on the mediastinum, which is moved towards the right. So it's a quite severe pleural effusion. Okay, we move to the other image. in order to see what's different. So, Joachim. Thank you, Halime.
Yes.
Thank you.
Okay. Okay. Just a second. Here. What do you think is different? The most important difference between the two images?
Oh, sorry, my mic wasn't on. The mediastinal shift.
Okay. And how is it in this picture here compared to the other one that we discussed before?
Like, which way is it shifted? Or what? I don't
Yeah.
really understand.
How is it shifted? It is towards the opacity or it is away from the opacity?
Towards the opacity.
Towards this massive opacity that fills the entire left hemithorax. So, what do you think would be the cause of this opacity compared to this one here? What could cause a shifting, this kind of huge opacity associated with a shifting?
A pneumoperitoneum.
Sorry?
Like air, right?
Air, where?
I don't know.
A pneumoperitoneum is air in the peritoneal cavity, so in the abdomen. It's quite far.
Well, I meant like I forgot the word for it. I don't know. I'm having a blank.
Like a pneumothorax.
Yeah, that's what I was going with.
Okay, but the pneumothorax is pathology, is a lesion that gives us a hyperlucency. So an image that is hyperlucent compared
Maybe
to lung,
atelectasia.
darker. Sorry?
Maybe an atelectasia.
Okay, correct. So most probably there was an obstruction of a major bronchi in the left lung that conduced to a total collapse of the lung, because it's the only explanation why all the structure of the mediastinum are tractioned towards the this huge opacity, because it is a retractile opacity that is probably due to a collapse. So the entire left lung collapsed, and with it, it tractioned all the structures of the mediastinum. So when you find yourself, okay, Joachim, thank you. When you find yourself in this situation in which you have a massive opacity that fills an entire hemithorax, you will have to be very careful in studying the mediastinum shift. If the mediastinum is pulled away, is moved away from the opacity, is most probably that the effusion, the opacity is given by a pleural effusion. On the other hand, if we have a massive opacity and the mediastinum is shifted towards the opacity, is most probably due to massive atelectasis. Okay, there is something in between. If you have this kind of massive opacity and the mediastinum is not either shift away or towards, and it is centered on the film, it will be probably due to a mixed opacity that associates effusion with lung collapse. So this is how you have to think. If you carefully study these signs, you will easily reach your diagnosis. What you have to find other things to help you if you need. You can study, for example, the aspect of the ribs and the spaces between the ribs in the two different films. Here, where the lung is completely collapsed and it looks like it tractions the ribs and pulls them close together, the spaces between them narrows compared to the other side, and compared to this massive pleural effusion in which the spaces appear to be a little bit enlarged. Okay, so keeping this in mind, you should have no major problems into identifying this kind of pathologies. These are the major diagnoses, differential diagnoses that you have to make in the setting of a complete white lung. Okay, now this is a bit more tricky, so let's see who has a radiologist eye. We reach Maria.
Yes.
Okay, so let's move straight to the pathology because we are we don't have much time left, and I have a lot of things to tell you.
Oh, so I'm not. I don't have to describe like it's
just-
heterogeneous.
Just tell me what is the major anomaly on this chest X-ray.
Well, first of all, the edges of the lungs are not. It's like the right lung, the edge, it's higher than the left one. So the edges are not equally.
What do you mean by edge? You refer to the lateral edge, or the apex, or the what edge?
The inferior one.
The inferior. I think they are quite symmetrical. I don't see why. They are quite symmetrical. There is another thing. It is a very subtle thing and quite serious. Look towards the apexes of the lungs. Do you find something, they are symmetrical, or there is something wrong on one of the sides? Okay, if someone sees, please intervene.
It's like
I don't know.
little
They
white
seem
lines, little white marks.
There are white marks in the lung that represent vessels and interstitium, pulmonary interstitium. Another thing, someone else. Come on. Okay, so you have to pay very close attention to the lungs, and to make sure that on each chest X-ray that you study, these vascular margins extend all the way to the periphery of the lung. This is a sign that will tell you that the lung parenchyma is normally expanded towards the chest cavity. What we see in this film is that here on the right apical part of the thorax, we have a lucency that is situated here. It goes like this. And in this region, we see no vascular markings. What we see is a thin, very thin, opaque line that delimitates this vascular margin and the lung from this hyperlucency. This is a hyperlucency compared to the normal aerated lung adjacent to it. So what do you think this is? If I told you what's wrong now.
Pneumothorax.
It's a pneumothorax. It's a small pneumothorax. It's typical it has all the signs that you need to learn. That firstly, it accumulates in the most superior parts of the thoracic cavity because of gravity. It is a hyperlucency compared to the normal lung because it has no vascular structures over it, and it is sharply delimited by this thin bright line that represents the visceral pleura. So because the air entered in the pleural space, there was we will see a shift of the visceral pleura that covers the lung, and it shifts to the lung, and the air between the two pleuras will determine this hyperlucency with no associated vascular markings. So hyperlucency, no vascular shadows or markings, no visible lung markings over it, delineated medially by the thin visceral pleura, which looks like this thin opaque line. It represents a pneumothorax. I'm sorry. Okay. What would you do if you have a high clinical suspicion of a pneumothorax and you are not sure on the X-ray? Maria, what would you do? So you are in the ER department, let's say. You suspect a pneumothorax in one of your patients because, I don't know, it has a sudden chest pain. He's a person that smokes, that might have a chronic pulmonary condition. You think that he might develop a spontaneous pneumothorax, and you get the chest X-ray that is not quite specific. Maybe you're not quite sure whether there is or not a pneumothorax. What would you do next?
Like a chest ultrasonography?
Okay, to see pneumothorax, especially in this small quantities, is very difficult to do by chest ultrasound. I'm not saying it's not possible to view in some settings, some special settings, pneumothorax by ultrasound, but it is not the elective imaging modality. So what would you do beside an ultrasound? It will give you
CT scan?
a CT scan, correct. On a CT scan, you will find the thinnest quantity of pneumothorax, and you could be very sure that you have the right diagnosis or to inform what you think. Here are some cases which have both have pneumothorax in bigger quantities. Here is on the right side, so you have the same hyperlucency that surrounds the apex and the lateral part of the lung. It has no vascular marking, so see how clear and transparent this region is. It is delineated by the visceral pleura that covers the lung. The lung is a bit shifted towards the inner part of the hilum, and there is a bit of crowding of the vascular markings in this lung because of the compression made by the pneumothorax. In some situations where there is a valve mechanism that contributes to the accumulation of air in the pleural cavity. Every breath, every inspiration that the patient has will lead to air accumulation in the pleura without the possibility of it getting out during expiration. This is called a tension pneumothorax, and it is a major emergency in the ER department. In these settings, you will have this kind of image on the chest X-ray. Basically, there is an uninhibited lung. We see a diffuse hyperlucency that covers basically almost all of the left hemithorax. There is no vascular marking, on this hemithorax, absolutely no vascular markings. But what you see is this opacity here, which is nothing else but the entire left lung collapsed around the pulmonary hilum because of the very important quantity of air that entered the pleural cavity. So this is a tension pneumothorax. It associates with a shift in mediastinum. If you see the trachea is deviated towards the right border of the heart is a bit moved towards the right, and you also see an increase in the spaces between the ribs because of this major inflation of the pleural space. So small quantities of pneumothorax can be and are bestly identified by CT scan if you're not sure on the chest X-ray. If the air in the pleura is in a medium or high quantity, you should have no problem in identifying it by these signs that we discussed about. And keep in mind that this aspect is a major emergency, because the effect of the completely collapsed lung on the hilum and on with the shift of the cardiac cavities can compromise the venous flow return and can rapidly go into cardiorespiratory arrest. Okay, moving forward. What also another sign that is typical in this setting is a flattening of the respective diaphragm. You imagine that there is such a quantity of air here that will push the diaphragm towards the abdominal cavity. Okay, these are examples of chest CTs. They are viewed in a pulmonary window. You can see very nicely the lung parenchyma, and here, similar to the aspects in the chest X-ray, you see hyperlucency with no vascular margins. There is an accumulation of air between the parietal pleura and the visceral pleura that you can see here, like this thin band, hyperdense here. What you can say also on CT, there are a lot of more details regarding the underlying diseases in the lung that could have contributed to the pneumothorax. So, like in this case, you see some emphysema right under the pleural surface, and one of these bubbles of emphysema could easily rupture and cause pneumothorax of this size. Also, what you can see, and think is that you see these bands here are some adherences, some fibrous bands that connect the visceral pleura to the parietal pleura, which suggest previous pleural pathology, some previous fibrotic changes in the lungs and pleura, which are considered some aggravating conditions in context of pneumothorax. So CT of the thorax when you're not sure or you suspect major complication, or you need to know some more information about what's the underlying cause of the pneumothorax. And this is a chest CT viewed in a pulmonary window in which you can very nicely see the lung parenchymas. These hyper intense structures are vessels, and this thin radiolucent bands which have these thin walls are bronchi, and so vessel with a corresponding bronchi. Pneumothorax, fibrotic bands, and emphysema. Okay, so what is this? We will move to Muneb. I don't think she hears me, or okay. So Nicholas, could you answer?
Hi, doctor.
Hi. So about the most prominent disease you can see here, or abnormality. We skipped the introduction because we are late.
Oh, sorry. So if I look at the most obvious thing is on the one side is opaque the right word?
Okay, you have to specify at least the side you're looking at, just for me to be sure.
Okay. I think it's the left side. I'm having trouble
side.
seeing the heart, so I'm trying to orient myself.
Okay, it is the left side.
Well, it's very opaque, and then also, as in the last slides, having trouble seeing the vasculature of the heart as well. So it looks like it's a mixture of pneumothorax.
Okay.
And
liquid.
Liquid, yes.
You have described like basically very good. What you need to do from now on is to try to be a little bit more specific. Like you see a mixed image which is formed by an intense opacity in the inferior half of the left hemithorax and a hyperlucency in the superior part of the hemithorax. You can see that between these two different regions and different abnormalities, there is a perfectly horizontal line. This is typically of air fluid level. And this is called a hydropneumothorax. So it's a mixture of fluid in the most dependent site, being opaque, of high intensity, homogeneous, and of a lucency in the most superior part corresponding to the gravity effect, which is lucent with no vascular margins, which is delineated to the medial by this line, which constitutes the visceral pleura and the collapsed lung. It is free hydropneumothorax because it extends from one side to the other from one edge to another of the left chest cavity, and is typical of hydropneumothorax. You have to keep in mind every time when you see this perfect horizontal line, and you have to distinguish it from that concave meniscus that we see when we deal with a simple pleural effusion, simple free pleural effusion, which looks like this. So this is a concave border, and this is a perfectly horizontal border. And this is typically seen in the air fluid levels due to hydropneumothorax. Okay, very, very good. Could you say something more in terms of complications that you can foresee here?
Death?
Okay, no, we try to fix this patients. So you
Yeah, I'm not. It doesn't look good. I know.
it
That's
doesn't
all.
look good, but
Yeah.
what extra signs of concerns can you see on this image? Besides the size, it's a huge hydropneumothorax. It's huge. This is suggested also by the fact that the mediastinum is a bit shifted to the right side. So it's a bit
Yes.
tricky. What else? The signs that I was thinking of, for example, are if you see this band here, is the only opacity that we find over this hyperlucency. This suggests that are some remaining fibrous bands that connect the pleuras, and that suggests that is a previous condition. Also, if you look at the contralateral lung, the right lung, you also see these fibrotic bands and a bit of interstitial changes diffusely distributed through the right lung. So we can think that there already is some chronic pulmonary condition that could lead to other episodes of pneumothorax or hydropneumothorax in this patient, besides the size and the shifting of the mediastinum, which is clearly not looking good. Okay, here are a list of pleural opacities that can be found and can be the cause of the things that we can see on chest x-rays. I will only insist on this kind of lesions, mesothelioma and metastasis. What you can see on this frontal film is that on the right side we find a reduced lung volume, and that circumferential on the right thoracic cavity, there are these opacities here that you can see, like nodular and thickening of the pleura. This is a sign of presence of soft tissue in the pleural space, which is highly specific of mesothelioma. Mesothelioma diffusely affects the pleuras. You can also have bilateral lesions. It is frequently associated with asbestos exposure, and it can lead to they are usually malign and can have a very poor prognosis. So keep in mind this kind of thickening of the pleura, which covers the whole surface of the right hemithorax, with reduced overall lung volume, lost volume in the right side, with this multiple opacities, so thickened and multiple confluent opacities that form these obtuse angles with the they are like this, just to help you a little bit to understand the thickening.
Hello.
Hi.
Hey, Joachim.
Okay, well, I guess that about sums it up. So we'll go study ortho now.
Please, I'd request my colleagues to wait another 5 minutes at least and just stay in the meeting. Thank you, guys. If you have any questions, just please raise your hand.
Okay, so what's this about?
Class, can you see my presentation?
This is actually the exact same slide I've been studying right now.
Okay, so today we're going to be talking about first aid in trauma. So we have the
Wait, can you skip forward to 32, slide 32?
yes.
It's about the scores, and I don't get it, like what they mean.
This.
Yep.
Okay, so what don't you understand, buddy? So we have the injury severity score, or the ISS. And someone please say something if the professor joins. I don't know, just cough or something. And so what don't you get, man? You got these here. You got the soft tissue, this stuff. You following me? No.
I don't think you really have to know how to like.
Yeah, I think I get it now because I didn't skip to the next slide, so I was still on slide 32.
Yeah, it tells you at the bottom what you're actually supposed to put in, but they're not going to ask you to calculate it. Just know that if anything has, if any of the abbreviated injury body areas have a severity code of a 6, then it's automatically a 75, and you don't have to worry about calculating anything. They're probably going to die if you don't help them. You get what I'm saying?
Yeah. Got it, thanks.
Yeah, I think class is over. So, any other questions or?